So welcome everyone and thanks for joining us for this webinar this afternoon on enhancing patient care through AI-driven digital pathology. We're going to make a start. We have got a large number that are joining us today, so thank you for taking the time through lunchtime to join us. We're really positive that the next hour will hopefully be a really useful part of your time as to how we explore that AI-driven pathology and how it really can help enhance patient care. Today's session is brought to you by the Royal College of Pathologists in partnership with Roche Diagnostics. So on that, please let me introduce myself. My name is Matthew Johnson. I'm the Director of our Access Medical and Innovation Group at Roche Diagnostics, and I'm going to be your facilitator this afternoon. It's my pleasure, though, to introduce today's speaker, Professor Sarah Coupland. Professor Coupland's a Senior Consultant Histopathologist at Liverpool University Foundation Trust with expertise in ophthalmic pathology, hematopathology, molecular and digital pathology, and also biobanking. So a real warm welcome and thank you, Professor Coupland, for joining us today. Before I hand over to Sarah, I just wanted to mention that the RCPath and Roche are collaborating on a series of 3 webinars. Today is the first in that series, and the second one is taking place on Tuesday, the 18th of November. And the second one focuses on our hospital, the 3 shifts, so our hospital to community, and that'll be with David Linden, the respiratory and CVD lead workstream at Yorkshire and Humber Health and Innovation Network. Our aim with the webinars really is to highlight the critical role that diagnostics and pathology play with implementation, and that successful delivery of the NHS 10-year plan. Today, the RCPath and Roche are also working towards a white paper on diagnostics as a key enabler of that plan, which we're hoping to publish in April of next year. And today's session is really meant to be focusing on that analog to digital shift in diagnostics. We're going to be conducting a couple of polls during the webinar to provide us with some insights that we really want to draw upon for that white paper, and we'd be grateful if you could take a minute or two to complete the polls now. And there'll be a couple more at the end. So I think the team should just be launching those polls as we speak. So the first one, we're just looking more of that role type. So if you would, please just dial into those and click where you can. The second one, to really assess that knowledge of digital pathology and how it's used by pathologists at the moment. The third, what's your current level of knowledge on AI and how it's used by pathologists? Our fourth, how would you rate that current level of experience in DP in your work? And then the last one, how would you rate your current level of experience using AI in DP as part of that diagnostics work? So if you would just please take a moment to have a look at those. I can see the numbers shooting up, so thanks to those of you that are already engaging within that. Yeah, thanks for that work. The numbers are really shooting up. We've got about 80% of you that have already voted on it. And as I mentioned, there'll be a couple of other polls just towards the end once we've heard from Professor Coupland and her presentation. So please join me in welcoming Sarah. And we're really lucky to have her with us today. And really excited to really hear a little bit more around DP and how she brings that to light. Sarah, over to you. Thanks.
Thank you very much, Matthew, and thank you for your kind introduction. It's a great pleasure for me to kick off this 3-part series, webinar series sponsored by Roche Diagnostics in collaboration with the College of Pathologists. So this is just an outline of my talk. I'm just going to start off to give you an overview of NHS England's 10-year health plan, and then what that means for pathology in general, and then I'll move on to digital pathology and AI, and then ultimately providing with you all with some examples of how that is being implemented, and then how we also have to be cautious with respect to the scrutiny of AI implementation in clinical care, and then summing up with a few conclusions, and I'm more than happy to answer questions at the end. So it's rather apt that the Labour Party is having its conference in Liverpool today, and by chance we had Wes Streeting speaking about the health service and some of the things that I'll be addressing in my presentation. So as you all probably know, in July 2025, the government released its 10-year health plan, and this was after seeking consultation at the end of last year. And essentially, it outlines 3 shifts, which I'll go into more detail during my presentation. But just briefly, there's going to be a shift from the hospital back to the community in the provision of healthcare. There's going to be a shift from analog to digital, where possible, with respect to records, patient records, and technologies. And then there is going to be a shift from prevention or to prevention, hoping that we nab diseases in the bud before they manifest themselves in advanced disease. So this was all on the background to the NHS health plan. It was based on a report which was put out by Lord Darzi essentially a year ago. And to be honest, and it was hit the headlines that the Darzi report was really quite damning of the NHS, saying that it was in an awful state, it was in a critical condition, and that it essentially needed resuscitation. That patients have experienced significant delays at all points of entry into the NHS system, in making appointments, in getting even at the GPs, and in tertiary hospitals, and then discharge from hospitals. We've all seen those on the television, and he said that the Health and Social Care Act from 2012 was a calamity and was really quite disastrous and had to be reviewed. There were missed targets, 62-day targets, and it hasn't been met since December 2015, so over a decade. And all of this contributes to a deteriorating national health compared to our counterparts in mainland Europe. And this is probably as a result of underinvestment over the years. And we've seen these cartoons and also protests on the streets, strikes, trying to counter and I guess make people aware of the crisis situation that the NHS is in and has been in for a number of years. And so in response to Lord Darzi's report, Keir Starmer acknowledged it, acknowledged that the NHS is broken, but says that essentially before anything can be done, reform has to be undertaken before significant funding is introduced into the system. So what are the 3 shifts? And I'm just going to go into these in detail to set the scene for not only my talk, but the 2 subsequent webinars. So with shift 1, yes, shifting from the hospital to the community. So there's going to be a shift in the health spending, the creation of neighbourhood health centres, which should be the focus points, the entry points for people when they're wanting to have treatment within the NHS. And these neighbourhood health centres should also engage with public-private partnerships to support them. There are going to be 2 different types of GP contracts, single neighbourhood providers and then multi-neighbourhood providers, which will deliver across larger differing neighbourhoods. With respect to shift 2, and there's something that I'll go into more detail later, is that there's going to be the shift from analog to digital, and digitizing everything where possible. And this will be the famous NHS app, the doctor in your pocket, something that I'll go into shortly. And that there will be single patient records such that patients can be seen wherever across the country, and that the patient records can be called up with ease, including images, and that the aim would be to use artificial intelligence where possible to reduce the amount of red tape that staff have to undertake when recording patient records, etc. So this is the app that I was referring to, and I believe it's been spoken about at the Liverpool conference at the moment in terms of what it's all about. But this is going to be the doctor in your pocket, and the wearable technologies such as Apple Watches or Garmin's or Fitbits will all be sort of this data will be included and taken or downloaded, uploaded into your NHS app, and this will provide additional information, background information for your GPs, for example, with respect to any cardiac dysfunctions which may have to be addressed, and sugar levels, possibly by various apps, which will be then fed into this NHS app. So yes, these single patient records, these technological tools for staff, all with the aim of making things more accessible for all of the clinical teams who may be treating the patients once they enter into the system. And I guess key proposals for the innovations are based on so-called 5 big bets, and these are AI to drive the productivity, genomics and predictive analysis, the wearable technologies, which I just mentioned, robotics, and this will not only be in the community, but also within the tertiary hospitals, and then investment in joined up data, so that the NHS data will be there and available for undertaking analyses to improve healthcare. The idea is also to establish new global institutes, which will be centres of excellence. And NICE, the National Institute of Health and Care Excellence, will be responsible for doing appraisal processes, looking at older technologies or innovations which should be retired, and evaluating ones which could be fast-tracked into the NHS. And last but not least, there'll be a single national formulary for medicines by 2028. So these are all the plans for Shift 2. Now we move to Shift 3, and this is an emphasis really on how do we prevent chronic diseases or acute diseases occurring. And this will be looking into education and increasing the healthiness of food sales within the community, also tackling this together with large companies who have perhaps an emphasis on processed foods. There'll be a rollout of mental health support, particularly in children and young adults. There'll be the establishment or revision of integrated care boards, which will be the designated prevention accelerators, and they will be mandated to develop population health improvement with local partners. Within these integrated care boards or ICBs, the aim would be to provide genomics or genomic testing at population level to pick up any rare inherited diseases or syndromic diseases, so that the patients could be treated at an earlier stage, such that they do not develop the fulminant disease. So these are the aims of the 10-year health plan. And I guess you could ask the question then, well, what does this mean for pathology? Is it business as usual? Well, to be honest, I think it's yes and no. Because if you look at the Lord Darcy report and even the 10-year plan, you won't actually find the word pathology, and you'd be lucky to also find the word diagnostics. So we've got to blow our own trumpet, we've got to shout from the rooftops, and we've got to emphasize how important pathology is in all of these shifts, and that funding should be incorporated in these shifts for pathology, for diagnostics at all stages. So we all, and I'm sure those who are listening to this presentation are aware that pathology and diagnostics are integral in all of these 3 shifts. It's integral in care, be it in the hospital or in the community. It's integral with the acquisition and uploading of any results, be they analog or digital. And of course, they're integral for the prevention of diseases. And this is seen in a, perhaps not this way that is represented by the 10-year health plan, but rather in a temporal fashion, in that, pathology is part and parcel from the cradle to the grave. At all stages of life, we have required, have had participation, inverted commas, with the NHS, whereby tests have been analysed. And this is just an idea of how many tests are undertaken each year. And these range from blood tests, urine tests, and tissue, which are all required to assess or diagnose for the presence of diseases, for screening, or for monitoring of treatments. And so pathology is key, is fundamental in all of these shifts, and is certainly in the temporal way as well. What is important is also that pathology is important for stewardship and for maintaining standards of the tests, and whether these tests are undertaken in the hospitals or in the community. It's really important that pathology is there to ensure that the tests are robust, they're reproducible, and they can be interpreted and then translated into clinical care. So as a result of this, we've combined together with Roche and also the IBMS to put forward this white paper, which is shouting out from the rooftops the importance of pathology in the power of testing, and how testing can be integrated in these three shifts. But obviously key to conduct any tests is the workforce. We need a diagnostic workforce which is robust, which isn't stressed, and which can conduct the work with high quality and with reproducibility. So key to this NHS 10-year plan is shoring up the diagnostics workforce, and also tapping into their existing expertise and leadership that we need to enact this 10-year plan. So some key recommendations which are coming out of this report is that the government should mandate equitable funding for diagnostics. When it comes to laboratory medicine, really a very small percentage of funding is given to diagnostics, and even though it's fundamental and yet often overlooked. So, and as I mentioned before, the government should tap into existing expertise and infrastructure for the implementation of its innovation that it wants to enact within the NHS. It should also look at papers, white papers, which have already been written by experts. So, for example, the Topple Review, which was written in 2019, and then last year, Accelerating NHS Digital Pathology Adoption, which was put together by a working group led by Deborah Paget, the former IBMS president, in collaboration with RCPath and industry. There are lots of recommendations in these two papers how the digitization of healthcare can be rolled out generally and also within pathology, so that some of these recommendations still stand and should really be considered. Similarly, other white papers have been written by the King's Fund and ABPI, how we can incorporate life sciences, industry partnerships, academia into the NHS to enable innovation and the development of new technologies and improvement of technologies in these three areas, in these three shifts. And I should also mention that even last year, together with Microsoft, a group from NHS England and IBMS, the experts came together how digital pathology could be rolled out beyond tertiary hospitals within networks in integrated care systems. So there's lots of brainstorming which has already been undertaken and has been written down, and there are lots of recommendations which really should be considered when rolling out these 3 shifts. But also, most importantly, we should be considering the patient and the patient's voice. Patients are a heterogeneous group of people. We too at some stage have been and will be patients within the NHS. We can pass on our experiences within the NHS and recommendations to the government and the rolling out of these systems within the integrated care boards and within the hospitals. So this study also highlights some case studies, which I just want to briefly go through. So, and they sort of touch on the differing shifts. So examples of a case study with, the involvement of the community, we saw many of those during the pandemic with a rapid community testing for the flu and also for new strains and emerging strains of COVID-19. We also saw the case study, which was put together by Manchester, where it looked at the so-called GAAD, or the GARD algorithm, looking at gender, age, alpha-fetoprotein, and des-gamma carboxy protein test, looking at risk groups who of the population who may be at risk of developing hepatic cellular carcinoma or liver cancer, and trying to pick this up earlier. And a similar program which was run here in Liverpool, looking at the Liverpool Lung Project, they devised an algorithm of so-called risk groups and then organized early chest X-rays such that the lung cancers were picked up earlier and then also obviously treated earlier too, with the aim of improving the prognosis. Case study 4 looks at a heart health event program, and this was there were 13 events which were undertaken in 9 cities, and in these events, festivals and things like that, they looked at the population in terms of measuring blood pressure, looking at the presence or absence of atrial fibrillation or any signs of heart failure. And then a simple test, an NT-proBNP test, was taken, and people who had any of these symptoms were then referred for cardiac evaluation. And then we have 2 case studies, 10 and 11, which were submitted by cellular pathologists associated with the RC Path, Adrian Bateman and Sebastian Brander, both highlighting the importance of what pathologists do every day when diagnosing, for example, cancers, looking at BRAF mutations, for example, in melanomas, or KRAS and other mutations in lung cancers or colorectal cancers. And then case 11 was looking at predicting risk in meningiomas, in a type of brain cancer, which was outlined by Sebastian. So these are just case studies how pathologists every day are integrating tests into the health system, and these can be integrated at the tertiary level or at the community level. But I want to touch now on digital pathology and AI, because I think when people speak about pathology and digitization, I guess the first thing that comes to mind is digital pathology. So what is histopathology? Well, I'm just going to use some images to perhaps dramatize the situation, and no offense, not all laboratories are like this, but biochemistry perhaps over a decade ago was really quite simple, and nowadays the biochemistry laboratories, the clinical biochemistry laboratories, are for the most part digitized with robots and very technically oriented orientated, although obviously manned, supervised, controlled, standardized by the lab staff. Histopathology, perhaps in contrast, still very much an area of pathology where there's this dependence on excellent skills in cutting very fine and unfolded and unblemished sections, and with the staining using a whole range of different stains. So, I mean, this, when it comes to perhaps placing histopathology in the development of phones and the progress towards a digitized, or like the latest version of the Apple phone, which I certainly don't have at the moment, but might consider investing in, we would probably still be here in this area. And these are images care of Michael Eden at the Cambridge University Hospital. So this is, I guess, a typical process in a cellular pathology laboratory, with the fixed and unfixed samples coming in, the samples being barcoded and checked and then put in cassettes, and as we know, then prepared for slides, stained, and then released for reporting by a pathologist, I guess, sitting traditionally behind a microscope. Over the years, lots of new technologies have been introduced into this workflow pathway, such that we have, have conveyor belts in some labs of all of the specimens coming in, and we have the automatic barcoding. We've got, the automatic embedding of smaller samples, automatic sectioning, even again of smaller samples. And I think what is becoming more and more a component of the workflow pathway are the digital scanners and the various screens from which the pathologists are now reporting their cases. So yes, digital pathology, a whole range of different scanners, and I'm not going to put a preference on any. And in some labs, you may have 10 scanners, such that the ones that specialize for cytology, others for tissue sections, and then these images can be downloaded onto a desk computer, or you can even be on your iPads, your iPhones, and use for teaching purposes. But I think probably what this is fantastic with digital pathology and the reporting of the images from the screen, is that it enables communication between the clinical teams, the pathologists and the clinical teams. It enables the communication, particularly at MDTs, whereby images can be called up, all sorts of images, radiological images, endoscopy images, etc., can be all called up, and then enhances the MDT experience, and perhaps also would improve on the time spent. So I'm just going to move a bit into research, and in such that digital pathology and the combination of AI essentially equals computational pathology. And whilst digital pathology in the first instance was instigated for improving accessibility in making diagnoses, now with the application of AI, it has enabled prediction of, for example, underlying mutations. It has allowed for improved prognostics, and it also can be used for the assessment and quantification of other components within the slide, such as stroma, vasculature, etc. Something that I'll come on to later. So I'm sure you've seen in reviews about digital pathology and AI all of these different neural networks which have been developed, and the foundation models and the deep learning models that are applied in different ways to tissue sections and for differing analyses. And as this article really quite neatly shows, this was in 2023, there have been massive increases if you just do a search in PubMed about digital pathology, AI, the application in research and in clinical care. And this was in 2022, and I can imagine that this curve has gone off to the top of the slide. And this was by a group in the UK, but similar studies have been undertaken in Germany, in Dresden, by Jakob Carter, who shows that digital pathology initially was perhaps concentrating on basic features, on morphological features, and in terms of grading and subtyping of the tumors. But then over time, it's been able to incorporate mutations, and using the data, then it's been, as I mentioned before, being able to predict from a simple H&E slide, you may be able to predict the underlying mutations and therefore predict response to therapies and also prognostication. And this is just an indication here on the right, the number of studies which have been undertaken and in all sorts of cancer types. But digital pathology, this is also just showing it is so, digital pathology and AI is reliant on large data sets, and the TCGA, the Cancer Genome Atlas, provided really a massive data mining exercise for researchers to look into their favorite cancer and even compare between cancer types. And such large data is also available in clinical trials, as, for example, here with breast cancer and metastatic colorectal cancer, which was undertaken by the N6 during the Innovate UK project. So it's not only applied to cancer, but it's obviously applied to a number of different diseases. And this was a very neat and I think landmark study looking into celiac disease, whereby 4 different hospitals did a multi-center collaborative study using 5 different scanners. And they looked at normal biopsies and compared them to inflamed and celiac biopsies. And an algorithm was developed, and then it was validated internally and then externally across these 4 centers. And then it was interesting to compare the model, the best trained model, with pathologists, the pathologist consensus, and also between pathologists. And you can see the agreement scores or the consensus which was obtained in this study. So it doesn't mean that digital pathology is going to replace pathologists, but it can be used as an adjunct. And this is obviously still very much in the research arena, but it's something that a tool which could be at some stage translated into clinical care. And I just want to say, and I know this is a very busy slide, but we've been essentially training our models, AI models, using tissue sections and perhaps using H&E only, but we may be incorporating additional stains, incorporating multiplex immunohistochemistry. So I guess increasing the number of dimensions. And we're also including other modalities, so radiological images. We may be including longitudinal data and also all of the associated clinical notes. So we're essentially creating a 5 or almost 6D model and digital bioresource when we incorporate all of these data into our records. And so this can then enable the decision supports. It can also help the design of new drugs and the planning of new clinical trials. So it's really an area which will probably continue to evolve and be of value for healthcare, but first and foremost in the research arena. I just want to show an example of what we're doing here in Liverpool. And I do specialize in ophthalmic pathology, and that's because there's one of the 3 super regional referral centres for adult eye cancer in Liverpool. And as a result of that, we see a large number of adult eye cancers, otherwise very rare. And we established an ocular oncology biobank, and it's now 14 years old. We've been able to extend the ethics such that we can include all of the ophthalmological images, all of the radiological images, include all of the genomics data, and also all of the clinical outcomes. And so this, in collaboration with Roche, also with a spin out of the University of Liverpool Arrow Technology, we've established a trusted research environment, which was launched in March this year. And we can, through this, we can really do lots of data mining. So if we have a number of PhD students working on this, can we use algorithms to differentiate a typical nevus at the back of the eye from an atypical nevus or an indeterminate lesion versus a choroidal melanoma. And so this has been undertaken by one of my PhD students who, together with Moorfields Eye Hospital, he slightly tweaked one of their foundation models, which was based on fundoscopy images of patients with diabetic retinopathy and glaucoma. And he came up with an algorithm which really, with high accuracy, predicted or helped ophthalmologists differentiate between a nevus and a uveal melanoma. And then another PhD student of mine, he looked at H&E sections of uveal melanomas for which we'd also undertaken the BAP1 immunohistochemistry, and the BAP1 is a surrogate marker for the BAP1 gene status. And if you have inactivating BAP1 mutations, then these tumors are highly metastatic, and more often not, they spread to the liver within a short period. It's approximately 2 years. And unfortunately, at this stage, we don't have cures for metastatic uveal melanoma in the liver. So he, Hongren, with high accuracy, came up with an AI model based on the H&Es only to predict whether BAP1 was present or not. Max is being given a further challenge in looking at the tiny intraocular biopsies of these tumors, and can he predict whether they are disomy 3 or monosomy 3 from the MGG stain only, and then something using longitudinal data through the regular surveillance scans, MRI scans of so-called high-risk uveal melanoma patients. We're looking to see, can we pick up these metastases earlier, such that then we can then refer the patients to the liver surgeon so that they can potentially have liver surgery at an earlier stage and improve their prognosis. So this is just an example of what we're doing in this sphere. And we're hoping to broaden it out to other eye cancers such as conjunctival melanoma, vitreoretinal lymphoma, and retinoblastoma. And we're hoping to link it in with the other super-regional referral centres such as Sheffield and Moorfields in London, and also in Glasgow, so that we could create a national trusted research environment for these rare eye cancers. And this is just essentially a pilot which could be rolled out into other tumour types. And indeed, this is what Louise Jones and Anita Goridias are doing in London. They've created an ecosystem. They were awarded a large amount of money through the grant funding scheme, and they are interacting with pharma industry, academia, with the Royal College of Pathologists, and also with Pathological Society. And they're concentrating on breast cancer and hoping that they can apply AI in better understanding the biology of the disease, predicting response. And this is really a very exciting exercise which is being undertaken in breast cancer, and is only funded at the beginning of this year and has been received considerable press and also support from health and policymakers. So just realize I'm perhaps running out of time, but I'm just going to move on to scrutiny and the importance of this with respect to AI implementation. So as you can imagine, there's a massive market out there for digital pathology and AI. And this is seen by the amounts of money which is being invested across the globe in digital pathology, and also the breakdown in terms of over the years. in the various regions, and also the projection of investment. So it's a big trend, and everybody wants to be involved in it. But I think what is important is to be aware that whilst there's lots of excitement going on, the number of FDA and EU approved and CE marked AI tools is not as many as those plethora that are being produced by through research, and Darren Trainer and his team, together with Danjit Basal, have put together, launched for the first time in February this year, a register of AI-based pathology tools which are available and have been approved for clinical care. And this is a live register, and so that is being continually updated by the team. They have also undertaken a systematic review and looked at artificial intelligence in digital pathology in a wide range of studies. They looked at close to 3,000 studies, and using certain criteria, they whittled that down to about 100 and then to 48, which were included in this systematic review. And they found that there was a significant heterogeneity in study design, and so some of these designs did bring in a clear risk of bias. And so they essentially emphasized the importance of evaluation of these studies and the generalizability of the AI tools if they've been conducted in single centers or using, for example, being applied only in one tumor type, or being applied using a limited immunohistochemical panel. And this is a study from this article showing that, yes, the number of AI models which have been tested in the different areas, and you can see there's considerable variation there, and as a result of that, also the mean sensitivity and specificities vary. So this does raise issues which have been addressed by people significantly involved in computational pathology about how it should be applied, and also the legal constraints and considerations of digital pathology and AI. So these are articles which I'd strongly recommend you reading. What's the college's position on it? Well, it does have a digital pathology committee, and actually it's been broadened out to other technologies. It made a position statement in 2023. Obviously, this will have to continually be also a live document being updated, but it is determined to engage with government and funders to gain support for digital pathology infrastructure and artificial intelligence. It will work with regulatory bodies to make sure that it's robust and safe for clinical use. It will also work together with so that there's training activities in AI for pathologists, and interact with patients and the public about AI, so that there perhaps is fear of the application of AI in diagnostics and pathology. The various myths are bust. And what I think is also important is where the college represents the UK. It has a large international membership, and so that it should interact with other countries and look how digital pathology is being used in other countries and learning from their experiences, so that we can implement any changes or standards required. So the college has been lobbying really quite intensely. Here's a picture of Bernie Kroll, our president, and Darren when they were called to meet with Rishi Sunak when he organised an AI summit. Sorry, I'm jumping ahead here. Then we have others such as Mike Osborne, who was representing NHS England, and Kath Halliday, and I was also present when West Streeting announced the call for consultation to the 10-year plan. We submitted a response to that, and so did other members of the Pathology Alliance. We're working together with other colleges, such as the College of Radiologists, and learning from them in how they've created networks for reporting. We're working together with the IBMS, providing advice for the recently announced further Carter review of pathology services. So looking into what needs to be undertaken to ensure that all of these 3 shifts can be enacted. And just last Friday, there was another call by the Department of Health and Social Care for inputs in how the workforce should be made fit for the future in the NHS. What are the priorities, and where should efforts be deployed? So just to summarize, I know that was really a whistle-stop tour, and I couldn't address many of the studies that I would have liked to have highlighted, but the NHS 10-year plan is a very ambitious one. It aims to ensure that the NHS stays fit for the future. Despite its crickety situation and its awful state, according to Lord Darcy, there will be a time lag before full realization and adoption of digitalization can occur. The college, together with members of the Pathology Alliance, is really lobbying hard to policymakers regarding the importance of pathology within all of the 3 shifts. We all know that it's fundamental, but unfortunately is often overlooked. We have to force the government to acknowledge that funding is required for increasing and upskilling the workforce, improving the infrastructure, improving limb systems, image storage capacities, system security, which I didn't have a chance to go into. But pathology obviously has a key role in digital stewardship, wherever it is located, be it in the community or within the hospitals, and maintaining standards. It does represent a window of opportunity at the moment. We can't be pessimistic. We've got to be determined to put forward our case. We've got to leverage insights from other digitization initiatives, such as in radiology. And all we can do is really collaborate with academia, industry, and other stakeholders to catalyze this transformation and enable this 10-year plan of the NHS. So with that, I'm going to stop sharing my slides, and I'll turn back to Matthew and Penny. Thank you very much for your attention.
That's brilliant. Thank you so much, Sarah. We really appreciate you taking the time to go through that. Before we look to the questions, please take a look at the questions that have already been asked. If yours isn't there already, or you see one that resonates with you, please upvote them, and we'll try and address those within the last minutes that we have. Now we've heard from Sarah, you should start to see some more of the polls coming through on your screens. We'd really appreciate it if you could take part in that just before we move on to the questions that we might have. Brilliant. I can see the numbers kind of launching and going up. That's great. So while everybody is just having a look at the polls and responding to those, thank you for doing so. We do have a couple of questions that have been put in the chat, and I think the most popular one that we're seeing was from John Firth, and John was just asking, approximately 28% of over 75s either don't have a smartphone or don't have access to it. What are the risks of exclusion in the new digital era? Sarah, what's your thoughts on that?
Sorry. I think that's a very pertinent and important question, considering that the population is aging because we're all living longer. It is highly likely, yes, as he says, that sorry, the polls keep on jumping in front of the question. It is highly likely that close to a third of the population doesn't have a smartphone, and or have difficulty using it, or have difficulty using an NHS app. And so this part of the population would be very much reliant on their relatives, on their grandchildren, to show them how to use it. And so I perfectly agree with John and the others who've raised that question, that there is a real risk of exclusion if everything is run via the phone. You even see that already with trying to organize appointments just using a laptop, or perhaps the elderly population having difficulty banking online. I mean, it's all, and the loss of the neighborhood banks. All of these things have an impact and can obviously lead to exclusion of certain populations. So I think it shouldn't be an either or. I think the alternatives should be there and available as well.
Yeah, absolutely. I think it's just about getting that balance right, where we've got to embrace that new technology. We still need to look at what else needs to be out there to serve the rest of the population.
Yeah, yeah, I
Brilliant.
agree.
We also have another question around how does AI-driven DP tools ensure accurate analysis across different tissue types and pathological conditions?
No, I think that's again a very, very good question, because you can, as in my case, you can concentrate on a particular tumor. You can refine that algorithm for H&E sections for that particular tumor, and the H&E sections being performed in your laboratory. And we all know that H&E sections differ between laboratories, so there is a need for multi-center studies in terms of just comparing the H&Es, comparing the platforms by which the H&Es or the sections were digitized, and then looking at, or how could we develop an algorithm, let's say for adenocarcinomas. Could that adenocarcinoma be used for adenocarcinoma of the lung, or those also in the colon? How generalizable are those algorithms? And so I agree that that at the moment we're still doing silo working, and we're not doing these broader studies. Perhaps the areas where we are doing the broader studies is looking at inflammation surrounding tumors, or fibrosis and connective tissue analysis around tumors. But that's perhaps the only broader, more general area that where we have cross-cutting algorithms.
Brilliant. And thanks, Abu Assad, for that question. The next one we've got is from Jacqueline Varley, and she's asking around how does AI-driven pathology fit with the NHS's desire to become more sustainable, given the apparent carbon footprint and savers acceptors it's looking for?
Also a very, very important question. Yeah, we all know how large digital pathology images are, and how much storage capacity is required to put them away, inverted commas, to archive them so that we can access them again. And it still remains a question and a topic of debate how long those images should be stored, compared to the glass slides and the blocks, and then yes, applying the various algorithms using large data sets obviously means that it's large energy producing, certainly not very sustainable, not really fitting into the sustainability agenda of the NHS. So unless unless other algorithms or coding systems are produced to reduce the size of the images but still make them retrievable with the detail, then perhaps that's an area that we may have to work on to try and get a tick box in the area of sustainability for AI.
Yeah, there's definitely that balance of effectiveness and efficiency versus the effects that it has on the environment as well. We've probably got time for one more question. So if you are still upvoting, please give this your last chance. But the last one we're probably going to cover off is, as more individual standalone AI tools are developed, are we going to need an overarching kind of meta AI to advise us on which tool to apply to our case?
That's also a very interesting question. I mean, obviously there are suggestions for the application of AI to as an aid to suggest which tests we should perform if we're encountering a particular disease or particular tumor. But having an overarching meta AI program, that may be in development, but I think probably would require, in the first instance, would require sort of a comparative study of all the different AI algorithms out there. And without wanting to create any controversy, then there'd be obviously competition between the various companies, or even HEIs who've developed these algorithms, as to, they'd be defending their algorithm over another. So that meta AI device might be a bit controversial, let's say.
Yeah,
I think it could well be of value.
Yeah. Thank you so much for the questions that you've asked. Unfortunately, we're on the last minute, so we won't have time to kind of cover the rest of the ones that we had there. But I wanted to take this opportunity to just say a huge thank you to Professor Coupland. Really insightful to hear your perspectives. And thank you for taking the time to prepare and share your views this afternoon. We really hope that you can join us for our next webinar that's taking place at the same time, 12:30 on the 18th of November, where, as I mentioned, we'll be focusing on that shift from hospital to community and really demonstrating that role that diagnostics plays within that. I think we all recognise that the NHS is absolutely at a crossroads, facing that unprecedented pressure. We've recently launched a new report in collaboration with RCPath, IBMS and the ALM that's focusing on the power of testing, and it really talks about how we unlock the potential of IVDs to transform healthcare and improve lives. What the report is offering is really that blueprint for navigating these challenges. And we didn't really want it to just be a report, but we wanted it to really look to be a roadmap for how more efficient, preventative, and an equitable health service. We really want it to show how diagnostics are undervalued, which, as you know, inform over 70% of those clinical decisions, and how they can be really key in taking that shift from hospital to community, reducing cost, and really looking at how it empowers patients. If you want to read a little bit more of that, there is a QR code on the screen where you can download your own copy. But I just wanted to say thank you for joining us today. We really hope you do have found it worthwhile. We'll be emailing everybody feedback forms. Please do fill it in for us. It really does help shape the college's programme of educational webinars. And there will be a recording of the webinar that will be circulated shortly after we've finished to those who have registered. And we'll also make sure that the video content is on the RCPath YouTube channel. So once again, thank you for joining us and have a really great afternoon.